I think it's important to say that leaks can happen with any device. The mechanisms are different. The definitions are different. You know, the leak with a Watchman device is different than a leak with an Amulet device.
Hey everybody, thanks for joining us on the Left Atrial Appendage channel. I'm Elliot Groves, the moderator for the channel. We have the pleasure of welcoming Michael Rinaldi. Michael is an interventional cardiologist with the Sanger Heart and Vascular Institute in the Carolinas, and it's affiliated with Advocate Health. He's a director of structural heart and is going to talk to us about leak with left atrial appendage closure devices. All right, Michael, please take it away.
All right, thank you for inviting me and having me. And I put this talk together to give you sort of my own perception of the way the concept of Peri-Device leaks have evolved in our current thinking. This doesn't mean this is the only way to think about it, but this is the way I think about it. And hopefully you'll find this interesting and it brings conversation. So title of this talk, All Leaks Matter, right? All leaks matter, but do they though? These are my conflicts for disclosure. So, do device leaks matter? I think it's fairly clear that we've come to the conclusion that even small leaks are associated with some increased risk of stroke. Remember, when we first started doing left atrial appendage closure with the Watchman device, we sort of said leaks greater than 5 millimeters mattered and leaks greater than less than 5 millimeters didn't matter. And that was probably pretty dogmatic. It was based on limited data. And then as we pooled the data, it became clear that even though the risk of stroke is much lower if you have a device in place, even with a leak, it's not as good as having complete seal. So it's clear that having a leak, even less than 5 millimeters, is less desirable, and we should probably strive to get as close to no leak as possible. One thing that's interesting is that even those small leaks are associated with an increased risk of stroke. It's non-disabling strokes. Nobody wants even a non-disabling stroke, but it's important to know that fatal and disabling strokes are not higher even with small leaks, so that's important. And what is the magnitude of that increased stroke risk if you have a peri-device leak? So it's not like it's not protective. If you have no leak, you have about a 1% per year risk of stroke. If you have a peri-device leak that's less than 5 millimeters, you have a 2% per year risk of stroke. That's much lower than you would have if you didn't have a device in place, and you'd much rather be at 1% per year. But it's a doubling, right? It's a doubling, but it's a doubling by 1 absolute percent per year. Not unimportant, but still protective compared to not having the device in place. And what do we mean by leaks? Are they all associated with the same residual risk, and do these matter? So from the left, you can have complete seal. That's wonderful. That's what we want. You can have a device that looks like it has complete seal, but it has possible flow through the fabric. Is that really a leak? Is that, you have patency in the back of the device? Are we missing something with CAT scan? It's hard to miss. Is there a hole in the fabric? It's hard to know. You just have flow, but you don't know the mechanism. You can have a very small peri-device leak that is much more difficult to sort of understand how that's mechanistically causing embolism. You can have a big uncovered lobe. That one's pretty obvious. That's a problem. You can have an edge fabric leak where it's not really a leak in of itself, but it's really coming close to the edge of the fabric. So there's really coverage of the whole thing, but there's a tiny little lack of contact between the fabric and the metal and the wall of the device. So these are all different, right? I can't imagine that the residual stroke risk would be the same based on all these things. It doesn't really make sense. So I think it's important to say that leaks can happen with any device. The mechanisms are different. The definitions are different. The leak with a Watchman device is different than a leak with an Amulet device. And having flow underneath the disc of an Amulet device may not be protective, even if the lobe is covering the appendage, because you have stasis behind the disc. So you don't know, and it hasn't been standardized. We don't know because we just hasn't been well enough studied. Large uncovered lobes are a plausible source of embolism. That makes sense, right? If you haven't really covered the entire appendage, then sure, you're going to have embolism. Yet small crescentic leaks are too small for thrombus to escape from the appendage in general. You can make an argument that if there's patency to the back of the appendage and the back of the appendage develops a clot, it could propagate through the small leak and cause clot at the device edge, and that would be a device-related thrombus. but we don't really see that. I'm not aware that we see much small leak as the source of a DRT. DRTs usually don't come at the site of a small leak. So it's unclear what the mechanism is. And that's important because, if you think about confounders, so even oral anticoagulation therapy has increased residual risk, even though you're taking a blood thinner. It has nothing to do with plugs, but oral anticoagulation therapy has residual risk based on your CHADS VASC score and also on your left atrial morphology, your left atrial size, and your left atrial appendage morphology. So by analogy, if it is plausible that small increased stroke risk with small leaks is confounded by other factors and is not directly related to the leak itself. And that's important because, if you're going to perseverate over closing small leaks, or you're going to think about coiling or doing unusual things or changing your device selection, you need to really understand if you're perseverating like greater than 3 leaks, get it, that's bad. But perseverating on leaks less than 3 millimeters, we don't want it, but are you really going to change strategy if we don't really know that strategy is going to make a difference? So one thing is important is, okay, let's hypothesize that a less than 3 millimeter leak is important. So the Amulet device, depending on how you grade leaks, but the Amulet device had lower small leak rates than the legacy Watchman device. That's not the device we use now, but the old-fashioned, old-school device, the legacy Amulet. If small leaks matter, one might assume that there would be a difference in stroke rates between Amulet and the legacy Watchman. But that's not what we see. Out in follow-up, we see that the Amulet device and the legacy Watchman device had no difference in stroke and embolism. So are we really sure that those small leaks matter? I mean, this was a reasonably powered trial. What we do know is that when you look closer at that Amulet IDE trial, that leaks greater than 3 millimeters were associated with a higher risk of stroke and embolism, but not leaks less than 3 millimeters. So I think, once again, size matters, but probably 3 millimeters is our new cutoff, not 5 millimeters. And it's really not being dogmatic. Uncovered lobes are bad. Crescentic small leaks may not be bad. And so I think this is really important. So here's a nice example of a small crescentic leak. Here is a 1 to 2 millimeter Peri-Device leak with a Watchman device. Does that really matter? What's the mechanism? How is that causing, we're not seeing clot emanating from this. Maybe there is, and we've just never seen it, but that's a possibility. So I think we have to be sort of thoughtful about this. So it's important to note that since the legacy Watchman device, we now have the Watchman Flex device, and then now the Watchman Flex Pro device. And the Watchman Flex device rarely has leaks greater than 3 millimeters. And a meta-analysis showed that the Watchman Flex device had actually lower leak rates and better safety than the Amulet device. And so can we say now that the problem of leaks has been solved if the Watchman Flex device rarely has leaks greater than 3 millimeters and leaks less than 3 millimeters of unclear significance? Well, let's look at some of the data. So the PRAG 17 trial, which was a randomized trial of Watchman device and Amulet versus Eliquis, showed no increased risk of stroke and embolism compared to Apixaban. Similarly, the Option trial, which was a Watchman Flex trial versus Eliquis or Apixaban in post-ablation patients, showed no difference in stroke and embolism. We'll also have the Champion study coming out, I think, in 2027, which will look at this as well. But you can make an argument now that since we've gotten rid of major uncovered lobes and major leaks, that maybe we're as good as oral anticoagulation therapy or even better. I think in the background, we need to think about how this whole field is evolving. So, people are now, instead of using general anesthesia and transesophageal echo, they're using intracardiac echo to guide these. To a large extent, this is because of lack of resources. If you don't have an anesthesiologist and you want to do TE, it's harder to do Watchman. So people who have limited resources in terms of access to their imagers and access to anesthesia will sometimes do ICE in a conscious patient. There have been arguments made that patients like it better, et cetera. But I think it's reasonable to say that 2D ICE imaging is not as good as TE. And that's particularly true in the hands of people who are not as experienced. 3D ICE is better. It has better resolution. It has 3D reconstruction. You can do NPR, but it's expensive. And even that is only as good as the imager using the device. And interventional cardiologists and electrophysiologists are not imagers by training. So I think you have to check our ego at the door. And there's a significant learning curve to all of this. What you can say is that the minimalist, no general anesthesia, no structural heart imager, ice-based procedure may be the only way to accommodate increasing demand as more and more patients are getting done concomitantly with EP procedures. And if the Champion study is positive and we end up opening the doors to lots of patients who are non-bleeders, we may not be able to have the anesthesia and imaging resources. So this may be the future. And that may be associated with more leaks greater than 3 millimeters, particularly in the hands of less good imagers or less meticulous technique. So this may only be solved by better imaging tools, which are coming, and better device iteration, which is also coming. So I think in summary, yes, leaks greater than 3 millimeters matter, but smaller leaks are less clearly associated with stroke and embolism. Leaks greater than 3 millimeters are really rare now with Watchman Flex, particularly with careful technique and appropriate appendage selection. The overwhelming majority of left atrial appendages can be closed with this technology. Spending time on deployment is important to minimize leaks. So I just had some cases a couple days ago where we had small leaks, and by recapturing and repositioning a little bit, I was able to get to 0 leak. But I think it is important to not to perseverate over the small, tiny leaks. If you can make it better, great, make it better. The Watchman Flex device is incredibly safe. You can reposition it with impunity with a very low penalty. But if the difference is a small leak or picking another device that may not be as safe, or which may not have better leak rates anyway, or leaving the patient on anticoagulation therapy or doing some kind of closure, that doesn't make a lot of sense to me. And there's some appendages that can't be closed or will give you small leaks no matter what you do, and that may be better than nothing at all. So I think it's important to put this into perspective. I think we went from no leaks matter greater than less than 5 millimeters to suddenly all leaks matter, and I think the right answer is to be more thoughtful about this. It has to make mechanistic sense. I think we have to follow the data, and I think we need to use some common sense. So I think the field is going to continue to evolve, but I think we have really good devices now. I think the Watchman Flex device is a particularly safe and a good device that can close most leaks with a small percentage of small leaks that are of unclear clinical relevance, and incredibly safe device. And so with that, that's my thoughts, and I'm definitely interested in any feedback you have. So thank you.
That was great. Thank you. Really comprehensive assessment in a short period of time. So what leaks are you intervening on? When do you say, okay, this one I actually do need to do something about?
So I think if a patient has a big uncovered lobe, that's when I would consider doing something different. I might put them on blood thinners. I might, I don't coil coil that much because I think that coiling or plugging with off-label devices has been shown that it can be done reasonably safely, but it hasn't shown outcomes data. And it's not clear that adding devices that haven't been tested improves outcomes. And I know there's some people who are very aggressive about that stuff because it kind of makes sense to them. And that's okay, that's a philosophy. But I think, putting coils in are thrombogenic, and that may not be better than leaving it alone. If you have patients that can tolerate anticoagulation therapy, then it's reasonable to talk to that patient about whether they just want to go back on anticoagulation therapy or they don't want to go on anticoagulation therapy and are willing to accept a 1% per year increased risk of stroke. And I think we need to be very careful about being aggressive, doing things like coiling to reduce a 1% per year risk of stroke in somebody where it's unclear that really helps. So I'm a little bit less invasive than some of the thought leaders in the closure space, might in the coiling and plugging for leaks space might be. And that's not to say that I'm right and they're wrong. It's that I don't think it's so clear. And I think it's important to have thoughtful discussions with patients about what we know and what we don't know.
Yeah, it's a great. I mean, I think I'm with you on coiling. I tend to, if I do intervene, which is, I think I'm more on your side of the less is more, I tend to use plugs kind of just for the actual leak. Because I still kind of, since we don't totally understand the mechanism of stroke with leak, it gives me the heebie-jeebies, for lack of a better term, to pack a appendage with a ton of coils. Great. And, I think one thing for me that's fluctuated throughout my time doing this procedure is sizing. How are you aggressive or less aggressive with oversizing your devices?
Yeah. So we have a really strong imaging department, so we CT everybody, and I really like CT, especially if you're going to do ice-based closure. I think having pre-procedural CT is great. I don't think you have to do that. I think TE is great modality, and that's what it was all tested on. I think it's important to oversize the device, but I think it's important to make sure, most importantly, that you just have stability. So that you have at least 10% oversizing for the Watchman device, and that it's really stable on a robust tug. I think passive aggressive tugging is a mistake, and I think you need to be very careful. One of the most important things is it's not just about percent oversizing; it's about looking at the back wall of the appendage. If the back wall of the appendage sort of tapers down in a wedge shape, and you have sort of like, you can have this ice cream cone phenomenon where it can spit out the device, and I've definitely the few cases of embolization I've seen typically happened in that kind of a case where you sort of oversized and the back of the device was more constrained and sort of ice cream coned it out. I think that's incredibly rare though. So I think as long as you have appropriate oversizing and you have stability on an honest and fair tug, instability and embolization are pretty rare.
Yeah, I mean, I guess, so where do you stand on, say, 10% versus 30? So the reason, I guess I'm trying to lead you somewhere. I suppose tell you why I'm asking. For a while I was being pretty, like more shooting for, say, 10 to 15%, and I didn't have many issues. But then I feel like maybe I'm going to blame somebody else, but partially we got a new clinical who was a little more aggressive and encouraged me to say oversize it, go one size up. And and then we were ending up with compressions like 25, 30%. And I think for a little while I was seeing that when I was post imaging, the device had moved out, even though I tug pretty hard generally. I was seeing that the device was a little more atrial than I would have wanted. And also my DRT rate went up from almost nothing to like, a fair percent. And I went back down to sizing more about like 10 to 15%. One of my friends always hates it when people say things like this, but I feel like my DRT rate went back to my baseline, and that wasn't seeing what you were describing as this kind of ice cream coning of the device. Any thoughts on that, or is this just something that?
It's a wonderful and very thoughtful sort of pickup. So I kind of agree with you. I think the sweet spot is between 10 and 20%. I think that if you over compress something, it can bunch the fabric, and it can lead to instability and movement of the device. And I think the thing is usually, for most appendages, I'm fighting for depth, and so it's pretty uncommon that I have so much depth that I can get a device that compressed. And usually I'm in the 10 to 20% range. I remember my good friend Sybil was always like, stuff the biggest device in that you can. And I respect him as one of the smartest guys, one of the best mentors I've ever had. But I definitely have come to the conclusion that there is a sweet spot. And usually I'm fighting for depth. So I can't get 30% compression because I can't get that big a device in. But I think what you're perceiving is probably very accurate. I think that, but overcompression may not be a great idea either.
Yeah. And the last question, how has your experience been with TruSteer? I think ours has been that we have felt like it has minimized leaks, and certainly we had Amulet mostly as a secondary device, as we can't get a Watchman, doesn't work properly. Our rate of that has gone down tremendously to the point we haven't implanted an Amulet in future, or in a while. In the future, we sure will. What's your experience been with that? Is it minimized leaks or just better implants? How do you feel?
Yeah, so I love TruSteer. I adopted it, and I use it on every case, whether I think I'm going to need it or not, because you can never predict how things are going to go. Even with the CT, you think something's going to be straightforward, and it isn't always. And so I find that the subtle movements that I can make by steering the device, both to get to where I want to on the back wall, and then also to sort of back the truck up and angle it, are super helpful. It's just, I think the only reason not to use it is if you're concerned about cost. To me, it's just not that much more money, and it just is not something like trying to pick which cases I want it in. If you don't use it, you're not going to, and you're struggling, you're probably not going to stop and switch sheets. You're just going to keep struggling. For me, it's just better to have it, and I never know when I'm going to use it, and I end up using it and not even thinking about it anymore. So I found it to be very helpful. It helps my deployment. It makes my life easier. It increases my ease of use, makes my agita go down. And so so I like it quite a bit. I personally, I used Amulet for a while. I stopped using it. Here's my feeling. This is appendage closure. This is not TAVR, where you're like, where patients die of aortic stenosis in a couple years if you don't fix it. Many of these patients can take anticoagulation therapy, they just don't want to. So if you have a really challenging appendage, Watchman Flex can close almost all of them. For the very rare cases where only an Amulet can close it, those are usually complex anatomies and aren't great for Amulet either. And it has a safety signal problem. And so to me, it's just not worth it. And so, I know there are people who love the device and use it, but I think the fact that Watchman Flex can close most appendages, and the ones that it can't close are probably complex for everybody's device. And there are always other options. It's pretty rare that you have a case where only Amulet can close it and that it's safe to close with the Amulet without a higher risk of embolization or pericardial effusion. That's my take.
I 100% agree with you. We kind of stopped doing that because I found that if it's hard to close, it's hard to close, irrespective of device. And I agree. I think your approach to TruSteer is very good. Initially I was kind of, because of the cost, even though it's it's not my money, but it's all of our money, I guess. I was trying to say, okay, let's look at we use TE for all cases. Fortunately, don't have an anesthesia problem. And I was trying to pick each case, but then I did have to switch. There was a few times when I was breaking on in the middle of the case, and I just said, hey, this is kind of ridiculous. So we're now pretty much doing it for every case too. So, well, thank you very much. This was a great tour de force review of this topic, and we really appreciate you taking the time to join us and contribute to our community.
This was a pleasure, and I really appreciate the invitation, and I look forward to hearing other people's feedback because, I think we all can learn from each other.
Absolutely. All right. Well, thank you very much.